key for you to listen for. If they don't have lung sounds on one side, it's because that lung tissue is starting to collapse to the point where it's not inflating properly.
During normal respiration, the lungs expand and contract within the chest cavity. The lungs are encased by 2 layers of tissue, similar to a fist that has been pushed into a balloon. The space between the layers, called the pleural cavity, is lubricated so that the lungs can slide comfortably across the chest wall. If air enters this space, it is referred to as a pneumothorax. One type of pneumothorax, called a traumatic pneumothorax, can be caused by injury to the chest. A blunt or penetrating chest injury can cause a small tear on the surface of the lung, allowing air to enter the pleural cavity and to become trapped. The pocket of air produces excessive pressure on the lung, causing it to collapse. A spontaneous pneumothorax occurs without injury as a result of certain lung diseases, such as asthma, emphysema, or COPD. Small air-filled sacs called phlegms can form on the lungs. If the phlegms rupture, they can release air into the pleural cavity. Pressure from the trapped air causes the lung to collapse. However, a spontaneous pneumothorax can also develop in a person with no obvious risk factors or disease. This condition is more common in smokers and in men between the ages of 20 and 40. Attention pneumothorax is a serious complication that can develop with any pneumothorax. If the pocket of trapped air cannot escape and continues to grow, the increased pressure in the pleural cavity can push the heart and major blood vessels to the other side of the chest. When this shift takes place, it causes a significant drop in blood pressure. This is a life-threatening condition that requires immediate medical attention.
If you notice when it shifted, did you see how the trachea shifted too? Now, you're going to hear the term jugular vein distension and tracheal deviation because that's basically what's happening. It's shifting the trachea and deviating to the uninjured side. And in the process, the jugular veins, because they're coming down here to the heart, they get compressed, so they get back up the blood in the jugular veins. So you'll see them starting to swell up. Those are really good indicators of tension in the thorax. Buildup has gotten to the point where the lung is almost collapsed. So just another illustration, like I said, whether it's a tension, or I'm sorry, a spontaneous or a traumatic pneumothorax, it's a life-threatening condition. You need to give them oxygen as quickly as possible, but then again, you need to get them to the hospital. They're going to need to get a chest tube, put into their chest wall, and take that air out of their lungs. Pleural effusion is another type of issue that goes along with the pleural space of the lungs. It's an infection in between the lungs and the pleura. And basically what happens is that that infection is very painful and it builds up on the lungs tissue so it can't expand out like it normally can. So treatment for infections is what? Nothing but what you do in the field. It's all in the hospital, antibiotics, things like that. The main thing you're going to find out is this person's when you're coughing a lot, when you listen to lung sounds, they're kind of raspy, noisy sounds when they're breathing. Just on one area. It's not going to be all over. Position of comfort sometimes helps them just by setting them up, and that helps some of that workload off of that area of the lung to make them have a little bit less pain in that area. So again, here's just another example. You get your peripheral pleura, and then your visceral pleura on top of the lungs, and in between there is where that effusion is, and the buildup of fluid and infection, which is causing that lung tissue to be decreased in space. Got to do it in the hospital. Again, it's another chest tube issue, and it's something that's going to require you to transport quickly. Patient having seizures can cause hypoxia, because again, if you're having a seizure, you lose the control of your nervous system. Your nervous system controls your respiratory system. So they're not going to be able to get ventilation in and out while they're seizing. Especially if it's a prolonged seizure, they're not going to be breathing at all. So you're going to need to ventilate these patients with a bag pump. If you've got a patient that seizes for more than 5 minutes, automatically suspect they're hypoxic and give them high flow oxygen with a bag pump. Sometimes you can get by with putting another breather on them, and as they're seizing, they still have some spontaneous respirations. You know, that will work for them. But if you're noticing that they're turning blue, and usually with seizure patients, they turn blue pretty quick, give them the backbone mask. Ventilate them as quickly as possible. It's not going to be easy because these patients, while they're seizing, are going to be jumping around, and it's just like holding down a dog trying to get to the bath. It doesn't work out well. But you're going to have to do it. These patients will die if they don't get that oxygen in the body. Aggressive treatment as quickly as possible. ALS can be called. We can give them some medications that will help stop the seizures, or at least calm them down enough where we can try to give them some better treatment. If they have an obstruction, whether it's tongue, whether it's food, get it out as quickly as possible, or try to realign it to prevent the obstruction altogether. You have a partial obstruction. How will you know it's a partial versus a complete? Okay. What do they typically do if it's a partial obstruction?
Cough.
Yeah. So if it's a cough, do you want to try to just go behind them and start doing the Heimlich maneuver and start beating them up? Yeah, you're going to cause them to be more scared and probably cause more damage than it's worth. If they're coughing, encourage them to cough. Keep them going. Don't let them stop. If they are completely obstructed, then obviously you need to do the Heimlich maneuver, or if they're unconscious, do CPR on them. Get that airway open as quickly as you can. We talked about the embolism a little bit ago. Again, this is basically a blood vessel, or a blood clot, or it's an air bubble that's trapped in the pulmonary vessel, pulmonary artery, pulmonary vein. And basically, if it's going to it gets clogged into a smaller artery or a smaller vein. If it gets into a major vessel, it may kill the person because that blood flow can't continue on. So the main thing to think about is that if they suddenly die on you, this may be the reason why they die. We can't tell it's pulmonary embolism in the field whatsoever. Doctors cannot tell it's pulmonary embolism at all. We look at signs and symptoms and possibilities. Patients that have been sitting on an airplane for 10 hours and not moving. Patients that have deep vein thrombosis, DVT. Patients that had recent surgeries, especially hip surgeries. They tend to have pulmonary embolisms. The only way they're going to truly diagnose pulmonary embolism is an autopsy. Because, again, it's just a small item, and we're just going to look to see where there's necrosis from no blood.
The circulatory system carries blood throughout the body via an intricate network of arteries and veins. The venous system is the section of the circulatory system that uses veins to return the used or deoxygenated blood to the heart and lungs. Occasionally, irregularities in the wall of a vein, especially in areas of slow flow, such as the area surrounding the venous valve, can cause a blood clot or thrombus to form. Once formed, additional fibrin and red blood cell deposits cause the thrombus to grow inside the vein. In addition to causing inflammation of the vein and obstructing blood flow, there is a significant risk that all or part of a venous thrombus may break off and travel through the bloodstream. These mobile thrombi can pass through the heart and eventually lodge in the small blood vessels of the lungs. The lodged clot, called a pulmonary embolism, may compromise blood flow to the lungs, resulting in shortness of breath, lightheadedness, coughing, and chest pain. Development of a pulmonary embolism is a medical emergency that requires prompt medical attention.
So again, look at things that tell you, is there a possibility? A patient that's been sedentary for a long period of time, recent surgeries, females with birth control. That's been always a risk factor that could possibly be called for pulmonary embolism. Sudden onset of difficulty breathing, that's probably the most common thing that you'll see. Chest pain, hematosis, pumping up of blood, or just all of a sudden they die. Or unfortunately situations where this may occur. If they're coughing up blood, make sure you're suctioning it out. Otherwise, get them to the hospital as quickly as possible. They can give them some fibrinolytics, which will dissolve the clot hopefully, and get it out of the way so they can restore it there and be done. If the patient's hyperventilating, what does that mean?
Breathing excessively at a rapid rate.
So when would we see hyperventilation? Drop. Good. What else? Most often mental disorder. What else?
Anxiety.
Well, yeah. Panic, anxiety. What else? You ever had a patient that was sitting there and all of a sudden started taking a beat? And it's that spasm of the diaphragm. They start hyperventilating because of that. So it can be a minor issue or it could be a major issue depending upon the severity. The main thing we're worried about is hyperventilation. They're starting to blow off excess carbon dioxide and they're not retaining it like it should be. So they start going towards the acidotic side of the pH scale. And that's not a good thing to have happen because, again, it can be one of those things where their body doesn't like to be out of that normal pH. It wants to be constantly happy. How do you get that pH back to normal? How do you reduce the oxygen level? Because we're telling you to give them oxygen, right? Can you give them a paper bag? Like in the old days, they used to give people paper bags and breathe in this paper bag. Most places don't carry paper bags anymore. They have plastic bags. So do you give them a plastic bag?
Put it over their hill.
It's not a good thing.
Our next pH word almost always gives people an unsettled feeling. Can't do this anymore. It's over.
What do you mean it's over? You can't do this anymore. It can't be over.
I'm done.
How can you be telling me? We just started.
Does recurring hyperventilating cause long-term side effects?
Oh my goodness.
Anyway. Forgot that. So don't let them breathe into a bag. Instead, give them oxygen with a non-rebreather. Because think about it. What's a non-rebreather doing? It's got a bag. It's got a face mask on top of it that's restricting some of the airflow going out of it, right? So use a non-rebreather, but do you set it at 10 liters? Why don't you set it at 5 or 6, right? You're still giving them air, you're still giving them oxygen, but you're also making them retain some carbon dioxide. And that way, maybe that'll help bring the level down a little bit. Now, again, how will you know it's hyperventilation versus extreme dyspnea or extreme difficulty breathing? What's some symptoms that may occur with hyperventilation? Well, obviously they're going to have chest pain. They're going to have this rapid breathing rate. And one thing that they always complain about is this. This is called CROA, muscle spasms. Lactic acid buildup inside their fingers. So if you ask them and say, did you ever have like these major spasms in your fingers? Yeah, I don't know what was going on. But you can diagnose hyperventilation, believe it or not. That is an easy one to do. So that's the only time that ever happens, believe it or not. In every disorder of the body, that is the only time you ever have these spasms, hyperventilation. You've got other issues as far as these exposures from toxic environments, work environments that may have some type of chemical involved. Sometimes, depending on what it is, maybe odorless, colorless, or they may be exposed to something so long that their body starts to develop a tolerance against it. It may need to be decontaminated depending upon what it is. How easy is a decontaminated person having difficulty breathing? If you've ever, all you firefighters with the hazmat stuff, and this is what we're talking about. We're talking about flush, strip flush. We're talking going through the 9-step corridor or whatever the case to do this decontamination. Most times with patients, we're going to strip them out of their clothes, scrub them down, do all kinds of stuff, and give them some stress to put back on. But they're going to need oxygen. That may be a little bit of a challenge because you don't want water to get into the oxygen tube. So make sure that you're caring for them as best as possible while you're doing decontamination should they be exposed to anything. Giving them oxygen, high flow oxygen, may need to be positive pressure with bag dogs or CPAP, depending upon the degree of what the exposure is. Getting them to the hospital as quickly as possible because they may need further treatment, further medications that we're around to give a gift. And then the last thing we're talking about here is some infections, just some MRSA, tuberculosis. TB is probably the most prevalent pulmonary disease that's out there. This disease is something that you'll see mostly in metro areas, not around here as much, luckily, but it's just there's a destruction of the bronchial and alveolar areas. And with TB, the problem with TB is it's very contagious. And I'm not saying you gotta be in the same room and that patient's gonna cough on you for 30 seconds. No, they gotta be with you and it's gotta be some direct lung contact or direct breathing contact for a couple hours before you get this. MRSA, it's more of a skin issue, but when it gets into the lungs, then it becomes a problem because it's something that they can spread by breathing. And you're gonna breathe it in your lungs and you're gonna catch it. So, very difficult to treat MRSA, unfortunately. Make sure you're doing everything like you're supposed to be doing, putting a non-rebreather on them, but you put a mask on you. And I mean like a surgical mask, not an oxygen mask. Okay? Giving them high flow oxygen, that keeps that crap in here and not out here. Assist them with the medications if they need them, bag them if necessary, whatever the case may be. With every patient, respiratory-wise, make sure you're notifying the hospital what you got, what you saw, what you've heard, and what you've done. Because they need to know what's going on here. Because if it's a contact patient like tuberculosis or MRSA, they don't want to put that in the general population of the emergency room. They get kind of PO'd about it. But if you got a patient like for a COPD, that's just chugging away like a choo-choo train, they're going to need some more advanced medications, maybe some RT, respiratory therapists, maybe some special doctors that are especially pulmonary doctors that are going to need to be on call for that. You're going to have some other stuff to throw out, the meter dose inhaler, and also the nebulizer. Now, meter dose inhaler, if they got this, you still should use it. If they tell you I've used it once, twice, 3 times, third time you can't. 3 times is the maximum dose for a nebulizer, or meter dose inhaler. And the big thing is, remember, with all medications with the exception of oxygen, you've got to call the hospital to get the order to give the medication. Now, I'm saying that now, and I know you're going to say, well, I don't do that out there. Here you do. In this classroom, when you go to take your test, you do. Don't get in the mindset that out there, yeah, you don't have to. We don't talk about that. We're going to talk about some other medications once we've done this class that you'll do out there, you don't do in this classroom. Okay, I don't want to confuse you. So anytime you want to give a medicine, you got to call medicine control. Make sure you tell them what you've seen, what you've heard, what you've done. Mother, may I? Yes, go ahead. Big thing about the meter dose inhaler, they can't help take the medication. And what I mean by that is you're trying to coach them into taking the medication, they just can't force their mouth up around the opening, or they're just not breathing in and holding their lungs from breathing in right back out again. There's no point in giving them. It's just a waste of time. If it's not theirs, they shouldn't have it in the first place. If it's a family members or friends, they don't take their usual medication, okay? It's got to be their prescribed medication. It's got to be like this. It can't be the little disc or the little squares or anything like that. It's got to be shaped like an L. This is a meter dose inhaler. If you don't get the approval from the hospital, obviously you can't do it. Now, before the local protocol, you can't do it that way. 3 is the maximum dose if it's expired. You pull it out, the chamber says that it expired last month. Can you use it?
No.
No.
No, it expired. And then any other things associated with specific medication. Now, for specific medications, there are some people that may have some peanut allergies. They may have some allergies to some other types of medications that are out there. Hopefully the doctor figured that out before you gave them the prescription. Okay? We can't help it. They hand us this thing, this is all we got. We can't give them something else. We don't have any other. So here's how you use it. Amazing.
Remove the cap from the inhaler. Shake the inhaler well for 5 seconds. Hold the inhaler firmly by placing your index finger on top of the canister and thumb on the bottom of the mouthpiece. Sit up straight or
Alright, so shake it, tell them to take a deep breath, blow it out. Either they can hold it themselves or you have to hold it for them. When they start to breathe in the next time, you hit them. You tell them, this is the most important thing, hold your breath. because that medication's gotta get from here to here. And there's no way you spray that thing in, and as soon as you spray it in, they got it anyway. They just gave it to you, probably, okay? So you gotta get them to hold their breath before this medicine does anything with the count. 3 or 4 seconds, that's about what you need. Then you can exhale, tell them to exhale deeply, and wait a few minutes to reassess it. 5 minutes is probably a good reassessment. After 5 minutes, reassess. Has it gotten any better? Because this thing, what am I going to give it? Am I giving it to a dry lung or a wet lung? Dry lung. Okay. So dry lungs, I should hear what kind of sounds? I hear wheezing. I should hear striding. Do I hear crackles? No, it's just wet lungs, right? So make sure you're giving it for that type of patient. The other medication that you can give is the nebulizer. And there's 2 medications that come for the nebulizer. You have the albuterol, you have the atropine. And with the albuterol, we'll turn lights on so that you can see a little bit better. If you have a patient that doesn't have a metered-dose inhaler, you can give them this type of drug. You're going to need a nebulizer. You're going to need your inhalers. What's the problem you see already? Same container, right? One of these, if the person has a peanut allergy, could be a problem. Which one is it? Yeah. So the only way I can tell you to tell is when you see different. Yeah. One's got an A at the top, one's got an I at the top. So that's the only way, packaging wise, you'll probably be able to tell because it's kind of hard to even see the printed name on the side of the container. So depending upon what the hospital's giving you or what your agency has purchased, that might be a problem. But again, hopefully you look at the package before you have to open it too. One was blue, one was green. That might help too. You can take your nebulizer and assemble it by taking your little T-piece to your exhaust, taking the mouthpiece to the other end, and then the little chamber is going to go plug into the bottom like so. So this is what the inside will look like. You're going to take your fluids, you're going to put it into the chamber. Now, albuterol, you can give that, like I said, there's 5 doses in the field. Atropine can only be given for the first dose. If you forget to give atropine after the first time, you give an albuterol, because you're going to mix these 2 drugs together. If you forget it all the time. You don't ever give it after the first dose, okay? So I'm going to mix it with the first time that I give this drug, it's albuterol. All you do is pour it in. Now, if you notice, I haven't hooked this up to oxygen. Why? Yeah, unless I want to face full of this stuff, I'm not going to do that. I'm going to wait till I get it all pre-assembled, have the nebulizer in the patient's hand so that they can breathe it in, ready to go. Because otherwise, again, it's going to splatter effect. What this does is the oxygen gets into this fluid and it boils it, causing it to become a vapor, which then they can breathe in. So I take my little oxygen cylinder here, put it on. And I'm going to plug it up and run it about 8 liters. Okay? So there's your vapor. Everybody should get it where it needs breathing. If not, patient breathes in deep, they exhale deep. Keep that mouthpiece in their mouth at all times so that they're getting that concentration of medicine in their mouth. It's going to take 5, 6, 7 minutes for this stuff to be rolled off. It cooperates when you want it to. Okay? And hopefully they're able to hold this and do this. Now, what if they can't hold this and do this?
You hold it.
Okay, you can hold it yourself. Or if you put a non-rebreather on them, then pop the bag out, plug this in. Okay, this will fit right in the mask, so that way they can not have to take the mask off and do it that way. But the problem is, once it does get done blowing all the liquid off, it take this off and put the non-rebreather bag back on. Don't just leave this on the mat, okay? You're not getting the oxygen concentration like they were. Okay? So that's your nebulizer. Now, don't tilt it. Don't let the patient cough a bunch of times. It's always going to do spilled medicine and stuff like that. Make them breathe. And you're really, as far as this medication, the inhaler, or the nebulizer, you got to coach them. You got to make sure that they are okay with taking this medicine and understanding how important it is to take it, because otherwise, they're not doing anything. They're wasting their time, they're wasting the medicine and all that. So you really got to get this stuff inside of them to function, to get the opening of the airways, and make their breathing a lot easier. What are some side effects of inhalers?
Jittery.
Okay. What else? What's it do to their heart rate? Okay. It increases the heart rate because it's a beta drug. What else are you going to have? Can they cough? Yeah, and they're coughing a lot because all this stuff is now starting to break up inside their lungs and stuff. Okay, so that could be something that they may have. It's telling you that it's doing like it should be. But definitely, if you give them the first time, after you check them 5 minutes later, listen to lung sounds again. Do they sound better or worse? If they don't sound any better, you may have to give a repeat dose. And I've seen, like I say, 5 doses given to field because the patients just don't open up like they should. This is a drug only for dry lungs. We don't give it to wet lungs. Make sure you do it the right way. All right, last thing tonight, epidemics versus pandemics. They want you to know that there are diseases out there that can be very problematic for the population, whether it's a flu-like symptom, H1N1, which is another flu that's out there, pig flu, bird flu. We've got Zika virus, all kinds of stuff out there that can be an issue on a huge population scale. So with an epidemic, we're talking about new cases that are starting to develop in the population area. Whereas with a pandemic, we're talking about a global scale. Like the Ebola issue, remember how Ebola was always like one small area? It never got out of Africa, it always stayed in Congo or something. That was an epidemic. Then it got over here last year, and that became a pandemic. That's the easiest way to remember. Big thing you got to remember is for any type of infectious disease, make sure you're wearing proper gear, make sure you're washing your hands, make sure you're getting all your vaccines as best as possible so that you're not going to have any issues. Some other things that I forgot about, foreign body airway obstruction or aspiration, especially fluids, get in the lungs, small pneumonias, and get it out. We suck those fluids out of the lungs. Yeah. So they're going to need hospital transport and stuff. You got a lot of people that have tracheostomies, there's little tubes in their neck area. That's where they breathe. They get mucus buildup inside of them. They got to clean it out with a suction unit. Most times the family is taught how to use those things, prepare for it. The only time we get involved is if the suction units break or they can't take care of it. So just transport the suction if necessary. We don't need it. We talked about treatment bronchitis already. Pediatric asthma, bronchitis. Again, these are disorders that we're going to touch a lot more in pediatrics later on in the class and stuff. Your still medications are still the same, but believe it or not, the inhalers are going to be a little smaller. They won't have that big chamber, they'll just be half the size. Now, albuterol treatments is the same dose for everybody. It doesn't matter. If you give a nebulizer treatment for a pediatric, an adult geriatric, it's always going to be the same dosage. Just remember that the albuterol, you give that as many times as necessary. Atrovent, first time only. You cannot give it in the second dose of that albuterol, the third dose. Pneumonia, we see that a lot with elderly, but it also is in anybody nowadays. It's like pneumonia. Can you tell if the person has pneumonia? No. You can look at symptoms. High fever, lung sounds, it sounds like it's got like a raspy sound in one small area. Yeah, you can do that. We don't have chest x-rays in the field yet, but you know, if you help kind of, you put pieces together, you start kind of identifying things that could be wrong with people. So remember, that's always a possibility. Pertussis was whooping cough, so this word is coming back, and I think we talked about with infection control. I mean, this is a disease that is highly contagious. If somebody's got a whooping cough, please make sure you're protecting yourself with a mask, and you put an oxygen mask on them to slow it down from getting out. And it's just this fibrosis we talked about, so we're there. Congestive heart, again. Next week you'll learn a lot more about congestive heart with cardiac disease and stuff like that. It's a very significant issue when it comes to the lungs being that's where the fluid's backing up at. And it's not the lung's fault, it's the heart's fault. With continuous pressure, CPAP, remember, what kind of patients need CPAP? A COPD, how about a congestive heart patient, an asthma patient? In order to get CPAP, what do they got to be?
Conscious.
Got to be conscious. Do they have to be alert and oriented?
Yes.
As much as preferable, but I mean, remember, there's going to be a little hypoxia, so they're ultra mental status, right? This thing's got to fit across their face as best possible. Giving them 25 liters, don't give them 50 liters per minute, because that'll blow their face away. But it's especially for patients that have a lot of buildup in the lungs, a lot of constriction, it works really good. And everybody that's been using it in the field is always been raving about it. So if you put this on a patient, make sure that you put it on according to the manufacturer's instructions, which come with the mask. Believe it or not, you actually have to sit down and read the manufacturer's instructions. Because some of these masks, they don't exactly fit on there like you think they should. So please make sure you take the time to look at the instructions. Reassessment wise, for every asthma patient, bronchitis, COPD, or chronic medical, whatever, how often do you reassess those patients when they're severe? Every 5 minutes. Okay. If I've got toe pain, and that's the only thing I got, you can reassess me what? 15. Same thing with some of your minor medical, some minor respiratory as well. Okay. Believe it or not, that was it. Now, hopefully, again, we're not expecting you to diagnose, we're not expecting you to go out here and start throwing out, oh, this is exactly what's wrong with you, and stuff like that. But look at what's wrong with the patient. Try to identify things that might give you clues as to, do they need just oxygen, do they need an inhaler, do they need a nebulizer? For respiratory diseases, these are your only things you're going to be able to do, other than getting them to the hospital for the treatment. All right? Okay, before we leave, we need to get this room back to the fire academy layout. So if we want to put your stuff out there, we can show you the table back together really quick. So let's take a look up here.
Tables across. How do they do this shit? Yeah, right. Are they straight all the way across?
Yeah, straight all the way around.
They're just 2 tables. Pretty sure they're split down the middle.
Yeah, they're split down the middle. 3 sections on each side.
Huh.
Well, 3
Table.
Yeah, I'll move this one.
One needs to go back, and one needs to go up.
Lunch.
What?
That table needs to go back.
Oh, you got one over